Assalamu alaikum and good evening. We begin in the name of Allah, the Beneficent, the Merciful. Welcome to our very first medical forum sponsored by Shelter Rock Islamic Center. The initiative is designed to bring most up-to-date scientific and medical information to the community that would be useful for everyone. I'm your host, M. Zakir Sabri. The topic this evening is very pressing that's affecting us all. COVID-19, a disease that has wreaked havoc by tearing apart families, by causing economic collapse and tectonic shift in our daily living. We have assembled a spectacular panel to answer some of the lingering questions for you this evening. Let's meet them. First of all, we have Dr. Farhana Sati. Dr. Sati is an infectious disease expert who had gained tremendous expertise in treating patients with COVID-19 disease. We have Dr. Nazmul Khan, who's an assistant professor of Mount Sinai Icahn School of Medicine. He's been a pillar of our community, and he's in private practice in Jamaica. We have Dr. Salim Shahzad, a scholar and a gentleman. He's an assistant professor and works as a pulmonary critical care attending at New York Presbyterian Brooklyn Methodist Hospital. We also have amongst us Dr. Yusuf Al-Mamoun, who's an assistant professor of Department of Medicine and the Queens Hospital Center, Mount Sinai Hospital in Queens. Last but not least, Dr. Maksud Chowdhury. Shouldn't call him a veteran, but he's perhaps the most experienced of us, a veteran pediatrician who is an associate professor at St. George's University School of Medicine. He also holds a faculty position in Downstate Medical Center and is in private practice in Jamaica. He is the president of Pediatric Global Initiative, a nonprofit organization that does tremendous work in the Indian subcontinent and beyond. But before we actually go to our panel, let's have some background for today's disease process. May I have the first slide, please? So the coronavirus, its name actually comes from crown-like spikes. So when you look at it under the electron microscope, it actually has a halo around it, since the name corona. We all are thinking that this is a new virus. The coronavirus actually has different strains, and it's been around for a while. There are 4 different subtypes that actually can cause common cold in 15% of the time. So these are the human coronaviruses. The viruses that causes problems and the ones that are lethal are actually the ones that can transmit from animals to humans. The plague that we've seen in recent days, there are at least 3 major ones to mention. First one was called MERS, M-E-R-S, the Middle Eastern Respiratory Virus, COVID virus. This was seen in 2012, 2015, and 2018. This was started in Jeddah and was very lethal, and mortality was upwards of 30%, but human-to-human transmission was not quite as common. So overall mortality was not that many. Before that, we had the SARS virus, Severe Acute Respiratory Syndrome COVID virus. This actually happened in 2002 in Shanghai, China. That went away, but it took almost 2 years for the virus to disappear. The current pandemic has been caused by a virus named SARS-CoV-2, Severe Acute Respiratory Syndrome COVID virus, coronavirus 2. SARS-CoV-2 is the virus that causes the disease named COVID-19. COVID-19 stands for coronavirus-induced disease, and the 19 was named after the year 2019. So let's go back to our panelists, because I think we can learn a lot more by talking to people who actually know and have a tremendous knowledge in this particular field. So my first question will go to Dr. Farhana Sati. Dr. Sati, can you hear me?
Yes. Can you
Well,
hear
welcome
me?
again. Yes, welcome again, and it's a pleasure to have you today, and thank you for giving us the time.
Thank you for
So,
having me over.
my pleasure. One of the things that has been talked about is when the virus initially came to Italy, only the elderly were supposed to be affected. Then it came to the States, and over a period of time, we realized that it didn't really follow any particular rule. So there are talks about having different strains of these viruses. So what I wanted to know from you is this virus, is this particular strain different from the one that was seen in the East Coast versus Italy versus that one that was in China?
Um, Basically, it originated in China, in Wuhan, and uh, it came to Europe and it came to United. Basically, it went all over the world. But what we saw when they did the studies on the virus genome, like the structure of the virus, they noticed that the virus strain was a little different that came to the East Coast versus the West Coast. And when they did further study, they realized that the virus that went to the West Coast primarily went from Wuhan, and the one that came to the East Coast came from Europe. And it did
Is this
mutate a
virus
little
different?
bit, but yeah, so this virus was different. The structure was the little bit they noticed that it was different, but it was and it caused we noticed that it caused a little bit more severe disease on the East Coast compared to the West Coast. The cases were less there. Is it because they started lockdown way earlier than us, or is it because what we saw in Italy, that the virus really infected a lot of people and claimed a lot of lives, and same thing we noticed in United States. It did affect elderly population more in Italy. It's possible because there is a big elderly population in Italy. And In New York, what we noticed that all age groups were affected. Especially, we saw a lot of young people between the age group of, I would say, like in 40s and 50s. We saw a lot of deaths, and this virus was very potent, very aggressive, and it didn't leave any age group. And then I'm sure that that we also noticed pediatric involvement
Right.
later on as well.
So one of the things that I wanted to ask you is that it actually affected across a large group of patients or regular people. But there are people that were able to withstand it better than the others. So who were at highest risk for getting the disease and who are at risk of dying?
Okay, so it's interesting. Basically, any disease or illness, when you see it primarily affects, basically your immune system is the most important thing that we noticed. That was driving the illness. People who got most affected were elderly, diabetics, people who have heart problems, and immune compromised patients, like who have cancer, they are on chemotherapy or they are on steroids for rheumatologic problem. They were the ones that were mostly affected, but we also saw a lot of healthy people getting affected by it. So basically, what it is your own immune system that determined how aggressively the virus affected you.
Well, thank you for clarifying that. So you've given us a list of risk factors of who would be affected and who would be more susceptible. But that brings me to the next question to our next panelist, Dr. Nazmul Khan. Dr. Khan, we just went over the risk factors of elderly people, immunocompromised people, people that debilitated. So let me just put you on the spot. Why did you get it?
Well, hi everyone, and thank you for having me also. It is definitely a big pleasure to be here to try to help the community. Now, why did I get it? As you might have seen, that this particular virus, it doesn't really choose between a person or who is going to get it or not. If you get it with risk factors like diabetes, coronary disease, you have kidney failure, or you're on immunosuppressant, as Dr. Sati mentioned, or you are with some sort of respiratory illness like COPD, asthma, all those kind of things, that your chance of getting much more aggressive sickness or getting some sort of serious complication is much higher than that. But if you see, even in this country, we have close to 1.6 or 1.7 million by now, I'm sure, people are infected, and most of them are not immunocompromised. If you look at the community where people got infected, not that everybody were immunocompromised, but those who got infected, if they are immunocompromised, complications or, I mean, fate is different. Those who have different bodies, resistance or immunity, they have responded differently. Personally, I don't have any one of those things, other than that I'm more than 50 years old, much more than that. So that could be one of the risk factor. I don't have any other known comorbidities that I am taking any medications for any reason that I am aware of. So yes, why did I get it? This virus is not really just infecting immunocompromised or elderly or younger or children. It does infect almost everybody if you are exposed to it. So I'm sure I got exposed somewhere since I was taking care of patient, and I got infected. And that is true for everybody else.
So we all keep hearing about how bad it can get, and we've seen patients how bad it can get. But you've actually personally experienced the catastrophic side of the disease. So can you, I hate to then put you on the spot, but I think it would be very important for us if you can share your personal experience at the worst moment of when you had the disease itself.
Yes, I can. And again, the spectrum of this disease's symptoms, signs and symptoms are very wide. There is no unique sign symptom, or it is not something that somebody or everybody is going to get the same kind of symptoms. As you might be aware, most of the audience most likely are aware of it, that in the beginning part, we always thought it is just a respiratory illness, that it just infects your upper respiratory tract, or might be causing some sort of pneumonic changes, mostly up to the lung. We didn't even think that it does involve lots of other system of the body. It is a multi-system infecting organism. It does involve almost every known system: your lungs, your upper respiratory tract, your kidneys, your heart, your brain, your vascular system, causing lots of different complications in the body. I mean, that was not, we didn't know about that in the beginning part of it. We always thought that it is not that kind of multi-system involving organism in the beginning part of it. And as I got infected in the beginning part of it, at the beginning of this virus pandemic, there are not too many informations available. I mean, let alone treatment. Treatment is not available as of now also. I mean, no specific treatment. But at that time, since nobody knew about it, everybody's target was just to stabilize you, to give you enough oxygen, and there was nothing else, just supportive care. I felt a lot of different thing, and most of the patient does feel the same way, I guess. You feel feverish, you feel tired, you feel very lethargic, your appetite goes away, you don't want to eat anything. And in addition to that, what was much more different is that you feel severely chilly and shaky, you feel, and you sweat a lot. I personally, again, I don't have any issue to mention that here, that I even passed out once. I was sitting in my dining room, in my kitchen, really, to eat breakfast, and I didn't know when did I fall on the floor. And my daughter went down, and she found me that I'm lying down on the floor. It could have been a minute or two or a little longer, I don't know. So those kind of thing happens to patient also, and they have some gastroenterologic symptom like nausea, vomiting, diarrhea. Somebody gets some diarrhea. So there's a wide spectrum of sign symptoms. Personally, I felt some of it, not all of it. And once I ended up in the hospital, It was mostly because of the respiratory symptom that my breathing was a little bit heavier than it should be. Oxygen saturation was a little bit on the lower side, about 90% or so. Luckily, I'm one of the luckier one, since I didn't have any other comorbidities. Most likely, I didn't have lots of complication. I didn't have to go for any invasive treatment. It was mostly oxygenation that I had to be supported with, and then they gave me a trial medicine. In those days, medicines are, most of them are trial. Nobody knows what it is, what they're treating for, what they're giving. I did take some of the medicine that nowadays is thought that you should not even take. It can kill you. So I have taken those medicine, and then luckily again with the prayer of everybody else and my luck and result of prayer of the community, I came back pretty easily without any other serious complications.
Well, I have to tell you that the community were continuously praying for your well-being and your shifa, and Alhamdulillah, by the grace of Allah subhanahu wa ta'ala, you are back amongst us, and so of the other brothers, and our fervent prayer goes out to those families that have lost the loved ones. And the fact that you brought up treatment, I think, because we touched up some of the symptoms, and people should understand that everybody had different degrees and varying symptoms, and there are people that had no respiratory symptoms whatsoever and actually had the virus. So a lot of things are unexplained that we still don't understand. Hopefully, over a period of time, it will become clearer. I'm going to actually jump to our next panelist, Dr. Yusuf Al-Mamoun. Dr. Mamoun had been at the epicenter in Queens and has extensively chronicled his experience in treating these diseased patients on a daily basis. So, Dr. Mamoun, first question I wanted to ask you is, as Dr. Khan had just mentioned, everything was experimental. We still may not be sure what works, what doesn't. But from your experience that you've gathered, what actually worked, or did anything work?
Thank you, Dr. Sabri. Thank you, everyone, for arranging this program. I'm always proud to be a member of this community. Nazmul Bhai said that during the beginning of the pandemic, it was really chaotic. We don't know what to do. Whatever recommendation, whatever news we saw in the website or social media, in the one time you can believe or not that we are treating using everything like ivermectin, hydroxychloroquine, azithromycin, HIV medication, everything. But as Dr. Nazmul Khan said that gradually we came to know how to manage this patient. In the beginning we started giving azithra and hydroxychloroquine everyone, but later we found that it may not be helping the people, or sometimes it may cause some heart problem. So then we stopped using the hydroxychloroquine in the hospital, but continued giving the azithromycin in some point. But basic the realization later on that the basic treatment for the disease was to symptomatic treatment and treat the complication. Symptomatic means patient was hypoxic, to give the oxygen. In the beginning we are giving only non-rebreather oxygen, nasal cannula or intubation, but later we change our hospital situation, make the more negative pressure room and using the BiPAP, CPAP or high flow oxygen. So that helps. Also, one more thing is very physiological, system that we didn't use before. That's the proning, putting the patient on their chest. That helps to lungs to accommodate, more breathing, space. So, any patient is hypoxic, like even in 84, 85, just moving the patient and putting them on their chest and belly, its oxygen saturation dramatically improved. This portion is a simple maneuver we didn't try in the beginning, but it's now very common. It's really helping. And others are some complication that, like in the fever, treat the Tylenol or acetaminophen, whatever it is. But the complication now, we know that the Nazmul Bhai said that he passed out. Some people came with a stroke. Some people came with a very short of breath. We are always thinking for lung maneuver, but we didn't think in the beginning it could be pulmonary embolism or the clotting manifestation or hypercoagulable state. Later, we all treat this, hypercoagulable state. We started giving the anticoagulation. For associated pneumonia, we started giving the antibody. For renal impairment, we started giving judicious amount of IV fluid. Then also some complication like the very common and dangerous thing that the cytokine surge, and that to prevent that or for treatment of that we started using the IL-6 inhibitor and or steroid, that all help to control the disease. And from I think beginning of the April, we kind of control the whole disease process, and the prognosis or the treatment modality is improved, and patient was were going home in stable condition.
So one thing that we've realized that we had a treatment approach to initially trying conservative, giving them the supportive treatment. But one thing that you brought up is the hypercoagulable state. We didn't initially think that people are actually having clotting problems. So can you tell us a little bit about what was the mechanism for so many people having kidney failure from this virus? Was it the clotting mechanism that caused the problem?
It could be. I mentioned that one time there is a cytokine surge. That's the real culprit. Is damaging the endothelial layers, and that eventually, also, inviting that, inflammatory system, inflammatory markers, and all damaging or leading to hypercoagulable state, and also, blocking or damaging the kidney system. So this all eventually, some people may ending up with the renal failure, having placed on the dialysis, and this all, and also some use of some medication in the beginning that may cause the damage to the kidney.
So it was actually a progression in learning as we're treating these people, because this virus is very different than anything we've seen in the past, and it behaved differently, it acted differently. I'm going to bring Dr. Shahzad into the picture because we're talking about hypercoagulable state and all that stuff. I want to break this. I want to simplify it for the general audience. We are getting some questions, and we are going to try and get to them in due time. I just would like to cover some of the fundamentals before we move to the question. So Dr. Shahzad, we sort of learned that if you didn't wind up on the ventilator, he had a better success of making it out of the hospital, because people who actually wound up on the ventilator, there was almost 80% mortality at some point. Now, why do you think that is? Number one. Number two, the ventilator-induced trauma, such as barotrauma, was there such a thing that may have played a role in causing some of the detriment in treating these patients initially before we realized that there was a mechanism, clotting mechanism involved?
Bismillah Rahman Rahim. Dr. Sabri for inviting me, and thanks to the Shelter Rock Islamic Center for giving me an opportunity to talk to our community here. I work as an intensivist. I can tell you from my experience just a line about this disease. It's not a disease. I would call it a syndrome. So it's not only a system with the respiratory wise. It basically is going to affect the whole system of the body. So as for your questions about the hypercoagulability state, basically, while it is affecting the lung, it is also affecting the various organs of the body. So once it affects the blood vessels or blood pipes of the body, it does causes inflammation and damage to the vessel, and that puts patient at clotting. It could be anywhere. It's in the vessel, it could be in the heart, it could be in the brain, where people are getting strokes, they can get clots in the legs. And those clots, they can move up to the lungs. So treating them is, first thing is you have to find it, where the clot is, so you treat it accordingly. And then we were doing some blood test, and which were giving us some clue, which is simple, is a D-dimer, we were finding which patients are at more risk for that. So if it was above 5 or 6 times higher than the normal level, we were thinking this patient could be. The other thing was, when the patients were more and more requiring oxygen, and they were not improving their oxygen level by giving, enough oxygen, at that point we're thinking, whether they are developing clots or not. So we're investigating them. One, we have a suspicion for that, and the second, once we get clue, we treat those. As far as your questions about the ventilator, I know it's a very common questions everyone, has asked me and other physicians involved. But let me put one thing forward, these patients, who require ventilator, those are the patients who are very sick patients. Majority of these patients, if we see, and my colleagues have mentioned, they have walked home. And so ended up of getting about 20% of the patients on the ventilator. So among those patients, if we look at the mortality, is different. Different studies have reported difference. It ranges from 40% to 70% of the mortality. And if we look at the recent study which came up yesterday from Emory University, they have 5 hospitals, about 3,000 patients, and their mortality of those patients who went on the ventilator was about 35%. Going back to the experience with the other, because this COVID-19 is causing, we call it ARDS, acute respiratory distress syndrome. The mortality from that in the past was about 35-40%. So I don't see a much difference from here. That in terms of the mortality, we have seen patients mean, if they have more comorbid conditions, their chances of death and mortality unfortunately being higher to begin with, and it gets much higher if they go on the ventilator. And if patients are young, they don't have any other comorbid conditions. I have seen patients, walking out of our hospital, though it takes time, because the virus is not only affecting the respiratory system, as we all colleagues mentioned, it's affecting the whole system of the body. So there are a lot of things going on with that.
So I want to be a little bit more medical before I go away from there. You mentioned ARDS. ARDS is acute respiratory distress syndrome, which actually happens when somebody is severely infected or have a terrible pneumonia or systemic infection, lungs get affected, we have difficulty oxygenation. Dr. Shazad, my understanding was that the difference between ARDS pneumonia and the COVID pneumonia is a lung compliance. In ARDS, lungs become more stiff, and it's difficulty in expansion, so we can't oxygenate them as well, as opposed to in COVID pneumonia, but there is more of a clotting mechanism that clots the small blood vessels, and that may have caused the difficulty in oxygenation. Do you think that's true?
Absolutely, I agree with you. It's not for every patients, who have requiring more oxygen, they have the thrombotic states. About 25-30% of the patients do have thrombosis, which we call it a microthrombi, which means a small amount of clotting. But there were patients, who had patients who are behaving like a regular ARDS patients. But I agree, maybe half of those patients have other issues and they were not responding to oxygen that much.
Well, thank you for clarifying that. I want to shift the gear to the pediatric population because initially, essentially, we are told that only the elderly, immunocompromised, people with tremendous comorbidities are at risk. And then suddenly there's a report came out, and before you knew it, 102 pediatric cases came up with very different symptoms. So I would like to invite Dr. Maksud Chowdhury from the panel. First of all, I was forced to learn about Kawasaki's disease in med school, then I forgot. In residency, I was forced again so I could pass my boards. Then I forgot all about it until about 3 weeks ago. I had to go back and learn what Kawasaki's disease was. So can you tell us what Kawasaki's disease is and how the SARS-CoV-2 virus may have an impact in mimicking the symptoms?
Assalamu alaikum. Thank you, Dr. Sabri, and special thanks to Shelter Islamic Center to organizing such a wonderful education program. So, the Kawasaki disease is a rare blood vessel disorder, inflammation leading to involvement of multiple organs like heart, kidney, respiratory, hematological, stomach, and all neurological disease. And this was described first in 1967 by Dr. Takashi Kawasaki from Japan. So their common presentation is normally fever, skin rash, swelling, peeling of the skin and hands and feet, and red eyes, cracked lips, strawberry-like tongue, this many red tongue, and enlarged lymph nodes. So because this is the exact cause of this Kawasaki disease, till now we don't know, but we're thinking most probably it is acute inflammatory condition triggered by some infection. Still, we do not know why it is, and most of the common the risk factor is a typical, they call typical Kawasaki disease, which is 6 months to 5 years of age. And it can get more than other age, even 6, 7 years of age, that we call atypical Kawasaki disease. And the typical, they present more than 5 years, 5 days of the fever. But in terms to the coronary, this COVID-19 infection, it is an inflammatory condition. And because of the infection, it does that's already our previous panel discussed, cytokine surge. Normally, you get it around of infection around 10 days of this infection, you get severe cytokine surge. This cytokine causes inflammation of the blood vessels, especially in pediatric age group. They develop in skin, they get rash, and they get also heart. When there's involved the heart, they got heart muscle inflammation, or it's called myocarditis, and they got rhythm disturbance and they got heart failure. Or they may develop coronary vessels, means heart vessels inflamed, they got ischemia and heart attack. So all this present with shock-like syndrome. So sometimes you hear also they talk about the toxic shock syndrome. It's very similar thing. The only difference is when a person gets infection, either you get viral infection or bacterial infection. When you get viral infection, they get a toxin release like coronavirus, COVID-19. The cytokine is a toxin which causes the inflammation of the vessels all over the body, especially the vital organs like heart, lungs, and kidneys. And in the bacteria, when the bacteria is infected, normally it got a streptococcal infection or staphylococcal infection, they release a toxin. It's endotoxin, which also causes generalized vascular compromise, leading to toxin and shock. So basically, those are both presentation very similar with the COVID infection. Luckily, these children is the condition is very rare. If you think of the coronavirus unless the child is a immunocompromised or chronic underlying chronic medical disease, majority of they do well. 91% of the coronavirus infection children is mild. You can treat they are not very sick. They can stay at home and you can need to monitor only. Only 9% they get moderate infection, but still maybe they need a little hospitalization and monitoring. Out of 9%, 1% develop this severe disease, which they need to end up with heart failure or respiratory failure, leading to ICU care.
Okay, so for my own edification, Kawasaki's disease, is it primarily an organ just involving the heart? That's strict
No,
Kawasaki, but because
Kawasaki,
COVID.
So Kawasaki, because of this typical presentation 1967 onward now, is generalized vasculitis, vessel inflammation.
Okay.
But the concern is the heart. When the heart vessels are inflamed, they get abnormal of the coronary vessels, leading to myocardial infection or heart attack.
That's associated, right? But the syndrome associated COVID-19 has been broadened a little bit than the Kawasaki is, and it's been called the multi-system inflammatory syndrome in children.
This is the term they use it, multi-system inflammatory disease in children. And the initial started when in Europe, they get first 2-3 cases, especially in the UK. So they get the term PMIS, in the pediatric multisystem inflammatory syndrome. When it comes to the USA, and like in New York, we got 146 cases all over the USA, and then CDC changed the name to multi-system inflammatory disease in children. Basically, same thing. So it inflamed all of the multiple organs involved, leading to myocarditis or renal failure or maybe skin rash. But so I want to reassure the parents, it's a very rare disease, and it's not that to be panic. Majority of they do well. We need a supportive care and close monitoring, and a few of the cases got worse.
So thank you very much for clarifying that, because my question to you would have been, what are you going to tell the young mothers, particularly my wife, who's been scared stiff since this report? So what should a parent be looking for in a child, and what should alert them to take them to a pediatrician or an emergency room?
Whenever a child sees a COVID-like syndrome, normally, as everybody has mentioned about the fever, runny nose, cough, in children they get abdominal pain and diarrhea, and so these are the common presentation about 91% of the cases. The few cases COVID, just like a mixed syndrome, like a multi-system involvement, they develop additional like a skin rash, and they look little bit, if it is very sick, they get other. So most important thing is evaluation and management. It depends on the guided by severity of the illness. So what we have to do, we have to ask the parent, when you see this kind of symptom like the child having runny nose, cough, diarrhea, or skin rash, but otherwise child looks okay. First thing is you have to call your child's pediatrician. So go through with the pediatricians will give a guide what to do. Basically, majority of the cases need a supportive care. Supportive care number one is monitor the temperature, give fever medicine. The patient child needs a lot of fluid because they're sick, they get a fluid. And the pediatric patient, if the child doesn't eat for 1 or 2 days, they get nutritional problem. So give a lot of nutritional support. And other things is that prevention to the other family member. Very important. Isolate the child. If there's an elderly people or chronic medical condition patients are around in their family member, isolate them and teach the child. If the child is a bigger kid, like a 5, 6, 7 years old, you teach them how to hand washing, cover the mouth, use a mask if it's possible, and keep them isolate the child. That is important thing here to do.
Well, thank you very much. We've tried to cover some of the fundamentals of the medical aspects of the disease. The part of this discussion that I wanted to take tonight is, what do we do? Where do we go from here? One of the questions that already came from the audience, and I'm going to actually aim it to Dr. Sati. The basic question is, do we know how it actually spreads? And in that regard, what precautions should we be taking, and should we still be hand washing, still doing social isolation? Should we still be following strict guidelines that we have been since the beginning of this pandemic?
Yes. So basically, as we know, and it's still the same, like, it has been told multiple times, this is a virus that is spread through droplets. What are droplets? When we talk, when we cough, we sneeze, we release small droplets of water from our mouth and nose, and they are heavy. So what happens, they stay in the air for a very short time, and then they settle down. They settle on surfaces, they settle on the floor, they settle on the counters, on the tables, and then what when people cough, sneeze, they touch their hands, and then they put their hands on doorknobs, switches, and then the next person or someone else touches those surfaces, and then it's a human. Naturally, we have a tendency to touch our face multiple times during the day. So it goes into our nose and eyes and mouth, and it spreads, it goes into our lungs and causes disease. So the preventive, the best way to prevent it is hygiene, hand washing, covering your cough, and social distancing.
So one
And
thing that
sure.
becomes very important of what you just said is that initially there are reports of this virus living on non-living surfaces for multiple
Yeah.
days, which was very
Yeah.
disconcerting. Do you think that still holds true? In other words, when
So
we bring groceries, should we be still cleaning them? Should we still be wiping? Because a friend of mine actually called me from Dallas the other day and said, I'm still going crazy wiping all these things. My neighbor doesn't seem to do any of that and he's fine. So how do you respond to that?
okay, so basically, in the beginning, they told us we all were very aggressive, especially we coming from work, and we especially when you work in the hospital, we were doing all these things. I was even washing my cell phone, cleaning everything, and same thing. A lot of even fruits and vegetables, I would put them in a little bit soak them and wiping everything. But what they recently updated and what they have noticed, that it is basically mostly spread from person to person.
Okay.
So that's why now you see the most they're stressing on covering your face with a mask whenever you are out in the public, and your hand washing, and obviously routine disinfecting of your counters, your bathroom, your surfaces that are commonly used. If you come from outside, hand washing is very important. And see the same thing you teach your kids and your family and everybody in the household. They also noticed that it was the virus was in the soles of the shoes. But as I said, right now I think the most important thing is human to human contact, and that is something that we're going to have to continue to do, for a long time, because we are expecting and we are talking about another surge in another peak in August. And I think the only way we can prevent it, because definitely we won't have a vaccine by then, is now that slowly the lockdown is being lifted, and people are gonna think that, oh, everything is coming back to normal, because right now we're not seeing a lot of cases. But the reason we are not seeing anymore, not a lot of cases like we were seeing before, is because everybody's locked down, everybody's maintaining social distancing, everything is closed. So I think the responsibility falls on our shoulders, that as these lockdowns are being lifted, we have to be very careful. When we go out, we have to cover our faces, put a mask and wash our hands and do routine disinfection that we, have been doing.
Well, one of the unfortunate outcome of this recent social uprising may be in the uptick of the disease. We certainly hope not, but that may be one of the shortfalls or poor outcome of the social uprising. But what
Yeah,
you just said is up. But the point that I'm sorry, but the points that you just made are really of paramount importance, because this relates to us in opening the places of worship. And when we all believe in prayers, but it is vitally important to at a minimum maintain the scientific guidelines and the CDC guidelines, because one thing we all have to remember, it's not so much about me getting sick, but it's my responsibility not to get you sick. And that's something that as a member of a society we all have to remember. Dr. Mamoon, I'm going to switch gear. I'm going to switch gear a little bit. We've seen this disease not discriminating anybody based on race, color, religion, faith. But having said that, the brunt of the disease has been borne by the people from the subcontinent, if you will. Can you give us some reasoning of why that is so? Is it strictly social, or do you think that there may also be a genetic component that made us more susceptible to this virus?
It's the
Dr.
evolving process. It's the evolving process. Still, in a lot of information we need to know. But as it came from China, our social structure, how we lived, we are very familiar. We like to stay together. We have the families. and like to state in the close approximately, and we have the grocery, everything we love to stay all together. And beside that, genetic, it could be playing a role. But another thing, I think, for socio-economic condition, if you see here, the most of the affected areas are here in the Jamaica, then Bronx, Brooklyn, but same way in the Manhattan is not that much affected. Even in the Long Island, it's not that much. People are getting infection. So it's kind of, I think, social structure that if you are in the close approximately, Dr. Shanti already mentioned that is coming. It's spreading through the person to person. If you stay close to a person, your chance of having this disease is much higher. And if you stay a little bit further away, that can help you out. Even in the staying in the New York City, if you go to the Westchester, upstate New York, even Binghamton, all those areas, they are not much hard hit area. So some kind of genetic factors, also our social structure and how we live together, and also the comorbid condition. I don't know you notice it or not, the lot of people who died, it doesn't matter young or elderly, they have some more other comorbid condition. We came to know later on that patient may have the Guillain-Barré disease, may have the asthma, may have the COPD. Some people, young patient, you may not believe it or not, they are in keto diet. We came to know that they are in keto diet for a couple of months, and they got this disease and they become very sick. So we are getting all this information gradually, but it's not only that getting the young patient is very easily and dying or ending up with a very complicated area. So it's a lot of things, comorbid condition, but still 80% cases we saw that it's a mild disease. Around 50% they are asymptomatic. So we have to focus on the people who are, and you mentioned that coming to the worship area is not only protecting us, it's protecting the community. If my elderly family in the kids are going out for play, but whenever they are returning home, they will be healthy, but they will bring it to your dangerous element to their parents or grandmothers or or the people who are sick. So that things we have to consider.
Well, this may be the end of someone on keto diet as I know it. And I'm glad you brought that up because I had no idea. I didn't know. But even people have mentioned that vitamin D deficiency may have a role because so many young mothers from our community died without comorbidities that we can't really explain. So genes may have a role. Vitamin D deficiency may have a role. Our diet may have a role. Where we believe in our fate, that's written, but we certainly have to explore what makes us culpable, what makes us vulnerable, and what we need to do to take the precautions of not getting it. Dr. Sazad, there are recent reports out of Italy that the virus may be weakening, and some of the disease, some of the patients that they are seeing with the same virus do not have the same manifestation as a severity as that was the case a few weeks ago. Do you think that there's any truth to that?
There's a possibility, Dr. Zakir. I tell you one thing, this thing came in USA, when we came to know about 3 months ago. And at that point, we knew there's no cure for the disease. And the other thing we knew, there's no definitive treat for the disease itself. So right now, we have the same statement, there's no definitive treatment for this syndrome or a disease, and there is no, definitive cure for this disease. So one thing, which you just bring up about these demonstrations, which are unfortunately happening in the city, there's no good thing about that, but there's one thing I will find out, because so many people are coming out without the mask and without the proper, masking and, protections. We might see a surge or we might not see a surge. So that's only going to be with the time, we'll find out. Initially, another thing which I would mention, we thought, this may be related to weather, But you could see, in Southeast Asia, in Pakistan, Bangladesh, and India, there's been so many cases right now, but the weather is very hot over there. So it is not weather related, only thing what I think is, based on the coronavirus, because as you mentioned, it's the MERS and the SARS, those were for short lived. So what I believe is, if something is a very hard hit and a very lethal and very contagious, hope that won't last forever, because right now we don't have a treatment. We've been so many trials going on. We've seen hydroxychloroquine fails. We thought, remdesivir has a very, marginal effect. The steroids, so many things. Only thing which we learned is how is this disease and a syndrome is behaving. What we're providing is just a supportive care.
Which brings me to the next point. If somebody walked in with a COVID pneumonia tomorrow, would you treat the patient same way, or how would your approach be different now than from a month ago?
Sure. So one thing is, there are two aspects to your questions, Dr. Zakir. One is, readiness. Right now, we have, learned or we have been educated, a lot more what things work and what does not work. So that is very important. Previously, we were not ready. We have a 20-bed ICU, and I can tell you within the span of time, we have expanded it to 110 or 120 beds with the same amount of physician and the same amount of response. So one thing is we would not have that problem. We're going to be ready for that. We would know what we will be doing. So talking about the treatment, again, I would repeat the same, there's no definitive treatment. I'm going to be doing more of a supportive care. So I can divide into two things, as we said, this is a viral infection or an illness. So one thing is, what thing I would do differently is, I would hit the virus very hard initially on, if I could. One thing which we have find is the medicine, which we talk about, that is remdesivir, that has shown promise. That's the only medicine I can tell you in terms of antiviral has shown some promise. I mean, the big trial is going to come out maybe in a few weeks to a month, which will find something is working. But that medicine, we might be using it early on. I can tell you a couple of patients which we have used it early on. I say one patient yesterday in my clinic, she was in the hospital for a month. She was on the ventilator. She has pneumonia. The only different thing which I saw with that patient was she got remdesivir within 10 days of treatment. So I don't know, that may be working, With the studies, we might not be proving it at this moment, but we may be doing it.
Thank you very much.
Transfusion.
Yeah, no,
Yes.
I'm gonna get to you on that recombinant thing, but Dr. Nazmul Khan, you've overcome the disease, and by all means now, I'm sure you've developed antibodies. So what is your thought on somebody with an antibody? Do you feel like a Superman, first of all? And secondly, do you feel invincible in a way that you're unlikely to have it the second time around?
Thank you again. Thank you again. No, I don't feel like a Superman. I still feel the same way. As a matter of fact, I feel much weaker than what I was 3 months back anyway. In terms of the antibody, I have antibody. I tested my antibody. It is positive, and it was supposed to be positive. That's a good thing. That I have antibody, it means that my body has responded to this infection. And I have been testing in my clinic almost everybody. Whoever walks into the clinic nowadays, I test antibody, even if they don't have any disease or had disease. And I have found quite a bit of patient, those who are positive antibody, they had very mild symptom, like maybe a fever for a day or two, a little bit of body ache here and there. And some people even didn't have any symptoms, especially the younger ones. But I made it a point that I'm going to do antibody on every patient who wants it, just to see how did these people really behaved during this pandemic time. Now, the antibody has a positive thing that it, like any other infection, if you grow antibody, it is supposed to be by science, by definition of science, that your body should have a protection. If you are exposed to the same virus next time, your body should not get in, it should not be infected. Or if you get infection, it should not be as vigorous or as aggressive as it is. You might get mild form of disease. So anybody who is getting antibody tested, have positive antibody, should not feel like that he or she is a Superman or woman, should not give up any of the protection or personal care mechanism that has been already mentioned: hand washing, using mask, avoiding any kind of public gathering, social distancing, whatever you call it, and staying safe, even if you have the antibody, because as of today, the antibody, we don't know how it's going to behave. Is it going to protect you fully? Is it going to protect you partially? Is the antibody is going to last forever? It is going to last for a few months. So there is no way to make any comment on the antibody right now, since this whole disease, this syndrome is very short lasting. But as we said, the antibody is going to be followed, and we'll see how people react to the next infectious process, if any, comes around.
Well, thank you for truly clarifying that, because people may have this misconception that once you have the antibody, you're immune to this disease, even though there are some studies that suggest a second infection, but there hasn't anything that has been retrospectively looked at, which one way or the other clarifies this dilemma. Dr. Siddharth, I stopped you short, but people that have antibodies can donate. And this reconstituted plasma, recombinant plasma, can be useful in the treatment. 90 seconds. Can you tell us, is it useful or is it not?
As I said earlier, one statement is always true. If you say it, there's no definitive treatment for this syndrome. So as of now, we don't have definitive evidence that if this works. If I spoke to other friends and so you were using it, they're seeing some observational data that it might be helpful. But as of now, we don't have a definitive answer for this.
Well, thank you very much. Dr. Maksud Chaudhry, we are a little over an hour, but I just would like to cover a couple of topics because I think these are very important for the community. 2 days ago, I came to learn of a really horrifying fact. And the fact is that child vaccination has dropped by 90% in New York State. Can you explain to us the risk of not vaccinating your child on time and why parents should not be afraid to go to the pediatricians and get their children vaccinated now?
So regarding the vaccine, actually, this is a the vaccine normally you're giving just like preventive care, but we don't want to the kid for just for routine visit to expose to the COVID infection. That's why initially we stopped to give vaccine. But the question is, the if you do not give vaccine, some of the vaccines will get quite high risk. Some of the vaccine already given 2 months, 4 months given. The 6 month vaccine was missing for 1 month or 2 months is not a problem. But if the vaccine is missing for measles vaccine, like it's dangerous. So we give a priority, give the measles vaccine if the child, because if a child gets measles infection, that causes immunological suppressed and it is dangerous. So that's why you have to think to prioritize the vaccine. Like measles vaccine, we do not have to delay. So
in other words, correct. So in other words, the childhood vaccinations, you would recommend that the parents take their children and get those very important. And if they have any confusion, they can call the pediatrician and see if this can be delayed.
They can call the pediatrician will decide which vaccine has to be given.
Oh, thank you very much. Dr. Sati, this brings me to my very favorite topic. And since you being the expert in the field, when can we expect a vaccine for this disease? And because there's such a big rush to have a vaccine, not only to find a cure for the disease, but this could be $1 trillion industry. So as much as we want a cure and as fast as we want a cure, what's the danger of rushing to get a vaccine out?
Well, the issue is, every vaccine needs to be tested. It has to go through a lot of phases: phase 1, phase 2, phase 3, and sometimes phase 4 trials, where you have to give you prepare the vaccine, you give it to a small number of people, you test it, you see if they're not developing any side effects. Then you have to, give it to a risk population, that is the one that really needs the vaccine, and you see if they are able to tolerate it. Like, if you give a vaccine to a young person to try for phase 1 trial, but in phase 2, if you know that COVID is higher risk infection for people who are elderly, so you're going to try on them, and then they have to try different doses. So to prepare a vaccine, it takes years. Yeah, here they are trying to expedite it, and that some of the companies have already done phase 1 trials. I think this is one of the vaccine that they are, with all what we went through, they're trying it. But that doesn't mean that they're gonna bring out something that is gonna be dangerous. Once they
Correct.
prepare the vaccine, they have to look at the safety of the vaccine, then they see if it's tolerable, then they have to see the efficacy. So I think it's gonna be some time until we really get a proper vaccine, which we are hoping by the end of the year or early next year.
So, you brought up the topic efficacy. We know that the influenza vaccine is very variable and sometimes may even have a 40 to 50% response.
Yeah.
Knowing what you know about this disease process, how effective do you think this vaccine will be?
What they are looking at is, that they are thinking that this virus, with flu, we have so many strains, and this influenza virus mutates. This virus also mutates, but so far, what they are looking at is not as a mutant virus as flu. So hopefully, the vaccine will be effective, but unfortunately it's so hard to tell. Right now we are still like so early into this disease that we haven't seen a lot of this as much. And right now, like we were talking about antibodies and stuff, that we know that people are developing antibodies, but are these antibodies going to be protective? And if they are, how long are they going to be protective? So right now it's very early to say anything like that how the vaccine, how effective would it be. They are, and it's not just here, the whole world is, in China, Europe, they are all trying to come up with vaccine, and they're trying to come up with different, when they prepare a vaccine, they basically, what they do is they take the virus protein or some RNA, and they inject into people, and they expect your body to recognize this as an infection when it's not supposed to cause infection, but it produces antibody, which is the protective thing that your body produces. So basically what happens is, when you give the vaccine, you expect that it will work and it will be effective. But I think it's just going to be a matter of time, and how once it comes out and once they start using it, that's when we will know how effective it is. And if this virus, hopefully, like Dr. Shahzad says, if this virus came out so aggressively, hopefully it's not going to be as aggressive and it mutates to something very mild form, like if they're what they are seeing in Italy, hopefully we can also see all of that. So then, this vaccine would be, hopefully not be a big issue. But I think it's very early to say that. But we are hoping, and what we are hearing is, by hopefully before the year ends or by early next year, we're gonna have the vaccine.
Thank you for clarifying that. I have a quick question for you from an audience. At what point should someone try remdesivir, and can I get it via prescription?
No, remdesivir it's a right now, it's like we heard from other speakers also, that this is not a proven treatment right now. Still in Gilead is giving it out as a trial medicine. So it's not that simple to get it. Hospitals are also getting it under they have to go through all this paperwork, and they have to go through the trial, submit and be a part of the research center to get the medicine. So it's not something, and it's injectable, so it's not something that people can just ask for prescriptions or get it. And the criteria to give remdesivir are also very strict. Not everybody meets the criteria. People with mild illness do not get it. Only, in the beginning we were only giving it to patients who were on ventilators, but now they approved it, and it's also given to people, patients who are in the hospital whose oxygen saturations are low enough that they meet the criteria. And also your liver function, your kidney function, everything needs to be monitored when you are on this medicine. So this is something that's only
Right.
given on
So,
an inpatient basis.
right. And correct me if I'm wrong, but it only comes in IV formulation. In other words, there is no oral formulation. So only
No,
way to get it is being severely sick and hospitalized. Um,
exactly. And then you have to meet the criteria.
Correct. So we've covered a wide range of topic. Dr. Mamoon, I may give you the last word because you touched upon this, I think, on one of your Facebook postings. Now that people are having antibodies, and there are people that have been asymptomatic and developed antibodies, the carriers who spread the disease, what is your feeling on herd immunity? And is it an attainable situation for us socially?
Thank you. Yeah, for any viral infection, we always look for the herd immunity. This herd immunity means in the most of the people in the community, ideally around 60 to 70%, at least more than 50% community members should be infected. It could be clinically infected, or they could be carrier, or subclinical infection could be there. And that usually, give you the protection from the reoccurrence of the infection. These cases we are expecting that one, but if you see that with the testing and everything, it's less than 20% basically it was infected, or that what is antibody. Yeah, the antibody was found in only 20% cases. But
Wow.
good thing is it could be little different. Dr. Shajad mentioned that, and I also tell that it's a good sign. Most likely Allah will help us. The recently last 1 or 2 weeks, I'm seeing the patient, we don't basically treating COVID anymore. It's really surprising, and you may tell me that why I am not treating, because there are some parameters what make us to make the decision to treat the patient, like hypertrophic state or inflammatory marker like C-reactive protein, D dimer, X-ray was horrible in the past, but now who are coming to our hospital with COVID infection, we don't see this anymore. We are not even giving Zitromax. We are not giving Tosi, or we are not even thinking for plasma. It's really, it's surprising. For last 1 month, even I'm getting the patient with the cancer patient, COPD patient. They have the COVID positive, but those parameters are in very low range. I'm treating just the cancer now. The patient with coming with the heart failure, I'm just treating the heart failure, not anymore the COVID. So the you mentioned that it could be by evolution, it may be getting weaker and weaker. Same thing happened in the China, Wuhan. After 2 or 3 months of a peak, it is kind of disappeared. Same thing in Europe. After 2-3 months of the peak, it disappeared, and it's showing in the New York City also. After 2-3 months of the peak, it's kind of helping us. It's not infecting the patient in that devastating form. And another thing could be the herd immunity. The infected proportion of the general community could be less. Maybe 2% is enough to develop the herd immunity against this virus. These all are evolving, but good thing I told you, it's becoming milder form.
Well, we certainly hope so. We've actually gone beyond our hour-long meeting. I had so many other questions. I feel like a kid in a candy store. But in the interest of time, we'd like to end tonight's program. My apologies if we haven't answered all your questions. Feel free to send us a question. Should there be need, I will try to reconvene another panel and perhaps try and get the experts together again to answer some of your questions. But from what I gathered from our discussion today, there is no clear protocol or treatment regimen for COVID-19 when it seriously affects somebody. So we can't be complacent. Virus may be weakening. Virus may not be as aggressive, but we don't know. Only time will tell. In other words, we still need to maintain the hand hygiene, the face masks, the social distancing, and we pray. But we do all those things and then we pray. Please call your pediatrician to get your children vaccinated on timely basis. They will tell you. The other thing I also wanted to mention is every one of us has taken utmost precautions before you open the doors. So feel free, because there have been a lot of catastrophes that have taken place because people are afraid to go to the hospital and people are afraid to go to the medical offices. I think we are at a point where the physicians have taken enough precaution that you will be safe for you to go see your family physician, your subspecialist, and should you need to go to the hospital, to go to the hospital. I wanted to wholeheartedly thank the super specialized and a talented panel that had given us the time. I'd like to thank the audience for staying with us. I would like to thank the ITV people for getting us a wider audience. And based on your demand, inshallah, we'll try to come back and shed more light on future subjects. May Allah keep us in the right path. May Allah lift this curse. May Allah give us the tawfiq to return to our extended families and to return to the places of worship. Thank you and good night.